All right. And then for CTs, now we want to get into heads, right? So big things to know about heads, you're always looking for bleeding. That's really the big thing you're looking for in head CTs. There's other stuff too, herniation, etc., but bleeding, bleeding, bleeding. You want to look first for bleeding, and then you'll look at the cisterns. You'll look at the general parenchyma if there's a huge territorial infarct. You'll be looking at the ventricles for things like NPH is what's one of the ones that they'll commonly test you on. And then the bones for any obvious fractures, nothing crazy. The first and most important thing, as I think I've emphasized, is blood. And the important thing is that acute blood, so blood that literally started bleeding minutes ago, that's going to be hyperdense. That's going to be white. That's going to be very clear. So this is acute blood, right? You see this whiteness, this white sort of appearance that's brighter than the brain parenchyma. Subacute, 1 or 2 weeks later. Here, I don't really know, right? I can't very clearly see where that outline is. I can tell there's something here because the ventricles are shifted, right? We have midline shift here. And this, I don't really see here we can see, for example, like the sulci very well. Don't really see that, but it's not nearly as bright as it was before. And then 2 weeks later, when it's chronic, it'll be hypodense, right? So it'll be, this is on the opposite side, but imagine for a second that it was on this side. This is the appearance of chronic blood, right? So this gives you the idea of how acute is the blood and gives you a sense as far as clinically how urgent is it that I intervene on this. And then there are, of course, locations, right? So there are locations of blood that have different meanings. So I'll go in a slightly jump around order. The first is epidural, right? So epidural is going to give you this lens shape, right? So this is the patient who comes in with a lucid interval, right? They got hit in the head, they were totally fine, talking, and then all of a sudden they pass out and come to the ED. This is that classic presentation of epidural hematoma. This is caused by a rupture of the middle meningeal artery. And this is a subdural. So this has that crescentic appearance, right? So you can actually see it even better on here, this sort of crescentic appearance. This one, you know, some of the blood is more chronic, for example, right? Because as we talked about, hypodense, but some of this is brighter. So some of this is acute too, but you have this crescentic appearance versus the lens appearance. And then we also have subarachnoid hemorrhage, right? That is actually within the cisterns itself because of, for example, a baryaneurysm rupture. And that you see this classic star, right? You see inside the sulci where they typically have the blackening of the sulci, you have this hyperdense material. Then you can have intraparenchymal, and then you can have intraventricular, right? So those are the classic things you look for as far as bleeding. But most commonly, they'll give you that presentation. For this one, they'll give you the lucid interval. For this one, they'll give you the chronic elderly patient who has had multiple falls. For this one, they'll give you a patient who has had maybe a history of, the most common thing I've seen is like ADPKD, because that's associated with the brain aneurysms and again, rupture, et cetera, subarachnoid hemorrhage. So they'll give you the history, but these are the key findings to look for on the CTs.
I would try to know the vessels as well for those.
Yep.
Subdural being bridging vein, epidural being middle meningeal. Those are important as well.
Yeah, definitely.
So taking us to our cisterns, then I think that these are things that I would say be familiar with, but I think knowing normal, seeing normal here really helps you identify abnormal. So I think that it's important to kind of know where these cisterns are, take a look at them. Most important here, though, is when we see these cisterns becoming effaced, and those are really significant for pathology here.
Yeah. Cistern effacement is really, when you see that, you're thinking about herniation. That is a big thing for you to be aware of for USMLE purposes. If you are not seeing the normal black spaces within the brain, think about swelling, think about herniation.
Absolutely. Okay.
Perfect.
And taking us to there, I mean, this is what we were talking about. I know that sometimes the medical terms are tough. So effaced, we're just saying that these kind of black areas that normally are there are no longer there. that's telling us increased ICP. If they were filled with white stuff, kind of radiodense stuff, that would be indication of subarachnoid, as she was referring to earlier.
Perfect. Awesome. And then, of course, you look at the brain parenchyma too for any massive lesions. Generally, it's not going to be subtle for these. So here, for example, you see this gross asymmetry.
I can't tell the one.
Are you having a hard time seeing this one?
Oh, okay.
Which side's abnormal? But then, so this is a huge MCA territory infarct, right? Clearly very hypodense on this side. And this is a huge cystic mass lesion, and this is causing midline shift, right? You can see the ventricles getting pushed over. You can see the sort of curving of the midline. So again, these are not going to be subtle. If it's like a 2 millimeter thing, don't worry about it. These are going to be pretty clear.
All right. So this person may present wacky, wobbly, and wet. So this is our hydrocephalus. These patients come in, and it's often, these questions are asked a little bit more in depth about kind of the underlying pathophysiology about normal pressure hydrocephalus and kind of the absorption there. So make sure you know kind of the details when looking through hydrocephalus. Anything else?
No, I don't think so. I mean, the big thing they're just going to treat, or excuse me, they're just going to test specifically NPH is the big one that you look for, because that's what they always test.
Yeah, absolutely.
And then bone. So this is, again, a little more advanced. They don't typically test this on the USMLE, but just what I generally try to use as a rule of thumb is look for symmetry, especially because some of this anatomy is very complicated. But here I'm looking at the orbits, right? Bilateral orbits. And here we have the maxillary sinus, and you can see here the inferior orbit here versus the inferior orbit here. We have a rupture of that inferior orbital wall, right? And you have rupture into the maxillary sinus space. And so that's just a fracture of that inferior orbital wall.
Major lesson here, guys, don't get in bar fights, you know, ophthalmology.
Yes, this definitely do not get in bar fights.
All right. Okay. MRIs, they are much less common, but they do present here. So we have some findings here of what we call Dawson's fingers coming off of the corpus callosum, but not getting too fancy here. Kind of some kind of white areas in the white matter here. And then also we're seeing some lesions here in the spinal cord as well. So this person may present with some variation in different neurologic symptoms in time and space.
Perfect.
Everyone's getting it after that.
Those key words, variation in time and space, was a buzzword for everybody.
Yeah, exactly.
Perfect. So yeah, as Blake mentioned, this is the clear thing here is these Dawson's fingers, thinking about MS. And this here, we also have the herniated disc as the additional finding here. And so the big thing I'll just quickly mention for MRIs, they're very, very rare on the USMLEs. And to be honest, I would be surprised if you guys got MRI questions, but it is important to have an idea of sort of what these things look like just in case, because they will be certainly tested. Because they expect you to know that Dawson's fingers is pathognomonic for multiple sclerosis. So really just knowing, Google it. Just take a look at the most classic example so you have it in your head for if they ever do. But again, far less common. Don't really need to worry about MRIs as much.
And, just a shameless plug for ophthalmology, but those retinal images are also just a high yield. There's really not too many of them. Only a couple diagnoses have retinal images, so it can be a high yield couple things to review.
Definitely.
There was kind of two main questions. So sorry, opening it up to live questions and answers. Sorry for interrupting there, Sana. But I was just kind of doing some skimming here, and it looks like there was kind of two main questions that I came up with. This one regarding PFTs. So it looks like I think the important thing here is you have to look at the FEV and the FEV1 and then the FVC ratios kind of separately and independently. And so for our restrictive lung diseases, we expect for both of the FEV1 and the FVC to go down, but we expect it to go down a similar amount. And so that makes the ratio actually stay normal. In our example, this patient's FEV ratio, FEV1 FVC ratio was 0.85. Over 0.8 is normal, making this kind of a normal ratio, but a low FEV1. And so that's more consistent with a restrictive pattern, having that normal ratio.
Perfect. Yeah. Nailed it.
All right. Sorry, Sana. Any other questions from any of other?
No, you said there was another one that you saw come up.
Yeah, there was an angiogram question. How common are angiograms on the USMLE?
Rare, very rare. I have not yet seen one.
Yeah, I would say I actually have seen one or two, but I would say that often those types of questions are questions that you would get kind of from the vignette itself. I think the one example that I had, it was a posterior circulation question. It's really kind of, I think it even had a picture of it, but then it told you in the vignette that they had posterior circulation. So you didn't really have to interpret the angiogram.
Perfect.
All right.
Perfect. And I know that we covered a lot, so I'll sort of wrap with our sort of parting advice about radiologic images. What I generally like to tell people is, as a third year, as a medical student, try and look at as many pictures as you can and try and look at it without looking at the report just to see, am I looking at the right things? If anything's grossly abnormal, am I seeing it? Am I missing it? Just to get a sense of what normal looks like. And when you have the time to do it, because that'll make you that much faster when you see the actual questions. And then the other thing is trust your gut. Use the vignettes, use the clinical history, because that is going to very clearly direct you in one way or another. And the findings are going to be obvious. They're not going to be very subtle cases. So trust yourself. If something feels wrong, then you're probably looking at the right thing. So sort of those two things. Look at a lot of images and trust your gut. Any closing thoughts for you, Blake?
No, I think you nailed it. Thank you so much, Sana.
Perfect. Well, thank you all so much for joining us. If you have any other additional questions, anything that comes up later, please feel free to reach out to us. Our contact information is on the slide here. But with that, I will bid you all good night and wish you the best of luck on your studying.
Absolutely.
Thanks, everyone.
Good luck, everyone.